Hello, I'm Michael Tambo, GP at the General Practice Unit at Fairfield Hospital and a conjoint academic at the School of Public Health and Community Medicine, UNSW. It is my pleasure to present the results of a study funded by the RSCGP Foundation conducted in 2014. My co-investigators are Louis Lyon, a medical student researcher, Professor Nick Swar, and Dr. Charlotte Hesby. This study examined the beliefs and attitudes of patients toward alcohol discussions with their GPs, specifically how acceptable or not acceptable these discussions are. Alcohol is a major contributor to the burden of disease and injury in Australia. It is second only to tobacco in terms of the burden from substances. In the general practice setting, about 1 in 4 adult patients are risky drinkers. GPs are in the ideal setting for early detection and offering brief alcohol interventions. They have access to the at-risk population and often see individuals before the onset of harm. Screening instruments are well validated and believed to be effective in primary care. However, effectively no GP uses these tools in routine practice. In a previous qualitative study of Australian GP beliefs and attitudes published in 2013, we identified 3 interacting factors that acted as barriers to early detection. The first that came through strongly was the stigma of being a problem drinker. Being identified or labelled as someone with a drinking problem was especially socially unacceptable. This led to the GPs perceiving that the histories they received from patients were inaccurate. However, probing into a patient's alcohol use behaviours was seen as something that could threaten the patient-doctor relationship. And thus the main issue. The successful implementation of alcohol screening in routine general practice remains elusive. And the context? We argue that patient beliefs and attitudes must be explored, understood, and used in implementation. This project had 3 aims regarding the acceptability of alcohol discussions between patients and their GPs. Firstly, does asking about drinking within a SNAP framework, which is recommended by the RSCGP, have an effect on acceptability? 2. There are suggestions from the literature that relevant reasons for presentation are important. Which ones and how? 3. What are patient beliefs and attitudes surrounding these consultation contexts? If there are effects, what are the potential explanations for these phenomena? The first 2 research questions were answered using quantitative methods with a survey experiment. The third research question used qualitative methods, semi-structured patient interviews, and analysis using grounded theory. All patients aged 18 years and older presenting to a community general practice clinic in an inner Sydney suburb over a week in May 2014 were included in the study. The initial medical records extraction identified 668 participants, but after excluding those that didn't actually attend that week, for instance, a phone call or home visit, and those without a valid postal address, 441 participants were included. These participants were randomized to receive 1 of 2 postal questionnaires. A total of 144, that is 66 plus 78, questionnaires were returned. The questionnaires recorded some demographic information, and the main section asked the participants to rate the acceptability to receiving alcohol questions from a GP in 20 vignettes. In the control version of the questionnaire, participants were only asked to rate the acceptability of alcohol inquiry in the vignettes using a Likert scale. In intervention questionnaire, participants were asked to rate the acceptability of smoking, nutrition, alcohol, and physical activity inquiry in the vignettes. The vignettes were based on the most frequent patient reasons for encounter and problems managed in Australian general practice according to the ongoing Beach study. The vignettes were short and written simply to a 5th grade reading level. They were expressed in the third person to reduce socially desirable answers. For instance, this is the vignette in scenario 13, which is a presentation for diabetes management. At the end of the questionnaire, participants could opt to leave contact details to participate in a potential interview. We purposely sampled from the survey respondents, looking to capture diversity and variation in the participants. We planned to recruit up to 25 participants and ended up interviewing 23. Saturation had occurred by this point. Semi-structured individual interviews were conducted, recorded, transcribed, and analysed in vivo. We used grounded theory as described by Corbin and Strauss. We used theoretical sampling, early interviews informed further recruitment and data gathering. Louis, who conducted the interviews, and I met weekly to discuss interpretation of the data during the analysis. Of the 144 survey respondents, about half left contact details. Going back to the three aims, for the first, the primary outcome measure was the number of vignettes out of 20 where alcohol inquiry by GP was rated as acceptable, and we compared the mean differences between the groups. For the second, we tabulated the proportion of ratings categorized as acceptable for each of the vignettes. For the third, we constructed an explanatory model. The results. Our participants were on average older, and about 2/3 were women. This is a histogram of the participant age groups. The green figures are the 23 who participated in the interviews, both men and women over a range of ages. Of all the participants, around 2/3 were married, and the cohort was especially well educated. Again, those who participated in the interviews. About 1 in 5 were abstainers, and over a third were risky drinkers. The spread of the interviewees. The primary outcome. Yes, inquiry about alcohol within the SNAP framework was perceived as more acceptable than inquiring about alcohol alone. The intervention group rated on average 2 additional vignettes as acceptable. This was a small, moderate effect. There were major variations to acceptability depending on the reason for presentation. Each of these bars represents one vignette. The green, proportion of participants who found alcohol inquiry acceptable in that scenario. Red, proportion who found it unacceptable, and white, ambivalent. From top to bottom is the ranking of the vignettes where alcohol inquiry was acceptable to least acceptable. These reasons for presentation were seen as highly acceptable. Almost no participant responded that alcohol inquiry from a GP was unacceptable. These next scenarios, notice that many more people were ambivalent, and these, less than 2/3 reported, rated them as acceptable. For the back complaint scenario, less than half thought alcohol inquiry was acceptable, and a fifth thought it was unacceptable. How do we explain these results? Our qualitative analyses of the interviews led to the construction of a 3-factor model. The perceived relevance of the alcohol dialogue seemed to have a major impact on its acceptability. Most patients seemed to have positive attitudes towards preventive care and health promotion as general concepts. However, within specific consultations, unless the inquiry was conceptually linked to an agenda in the patient's mind, it might not be acceptable. This might explain the large variations in acceptability depending on the reasons for presenting, and might also explain the improved acceptability of asking within SNAP. An implicit health promotion frame is in place. The manner in which the dialogue occurs is important. Collaborative and negotiated approaches were seen as more acceptable, whereas if the GP was seen as pushy, was seen as less acceptable. Lastly, patients reported unease with the moral dimension of alcohol drinking. If they perceived that they were being judged, or might be judged, they might be evasive, even bend the truth. To summarize the results, asking alcohol within SNAP does improve the acceptability of the inquiry. There are major variations to acceptability depending on the most common reasons for presentation, so patient acceptance to receiving alcohol questions shouldn't be assumed. The acceptability of alcohol inquiry can be explained by 3 immediate consultation factors: the perceived relevance of the dialogue, the approach and language of the dialogue, and the discomfort with the moral nature of drinking. There are a number of important implications for the implementation of risky drinking screening. Early detection strategies that require mechanistic application of a screening tool in consultations are unlikely to be acceptable to patients or GPs, and thus have a low likelihood of success. What might aid successful implementation? Alcohol assessment within SNAP or some other explicit health promotion framework. Setting the context improves acceptability. And with that note, priming patients about alcohol discussions prior to consultations with their GP may also create a context. Create the expectation that alcohol discussions will occur and that these are normal. This might be at a local level with practice posters or at a community level with initiatives like Dry July. Targeting screening to a number of common reasons of presentation, for instance, diabetes, hypertension, acute mental health, reflux disease, and checkup. These were seen as highly acceptable contexts for alcohol assessment. Lastly, we need to respect the moral unease. embedding a not today option in routine screening procedure is very likely to improve acceptance. Alcohol screening and brief interventions perhaps need to be reframed not as a singular event, but as embedded within the longitudinal care of general practice. An important limitation of our study is that most of the participants were born in Australia, the UK, New Zealand, or North America. Our study, like most others in the literature, was of people living in what is described as a temperate or ambivalent drinking culture. The perspectives of people from other drinking cultures are mostly unknown. The next step in our project in 2015 will address this. We are surveying the views of the culturally diverse people visiting GPs in southwestern Sydney. Our 3 publications from this project in Australian Family Physician. Thank you.